Hi, this is Rhonda Davis. I will be recording this lecture on rest, comfort, and sleep. Our physical and emotional health depends on adequate sleep and rest. As you guys know, without proper sleep and rest, the ability of the body to perform normally is affected. It is difficult to concentrate, to make good judgments with a lack of rest. Also, rest can help promote healing and help us to participate in daily activities. When people are at rest, they usually feel mentally relaxed, free from anxiety, and physically calm. Rest does not imply inactivity, however. Some people can rest by reading a book, taking a walk. Some use relaxation exercises. Some people may do computer games for rest. Sleep is a recurrent, altered state of consciousness that occurs for sustained periods. It is a cyclical, physiological process. You have the circadian rhythm and the biological clock. When we have the proper sleep, we do feel that our energy has been restored when we get up in the mornings. And the circadian rhythm is a 24-hour day-night cycle that is really affected by light and temperature and external factors like activities and environmental factors. Biological clocks synchronize sleep cycles. It is normally synchronized by exposure to light and activity. Some like to go to bed early, some like to stay up until midnight. Different people function better at different times of the day. Some of you may be morning people and others may be afternoon people. When our sleep-wake cycle becomes disrupted, especially like for people rotating shifts or for nurses that work 7 on, 7 off, and let's say they work nights, 7 nights in a row, and then on their off time they're trying to be awake more in the daytime, that really interrupts their sleep cycle. And other functions change as well. A lot of times people with sleep disorders always feel sometimes that they're not restored or they feel like they didn't get enough sleep when they get up in the mornings. Sleep does involve a sequence of physiological states maintained by our central nervous system. And it is a dual process. It has two distinct states that involves a sequence of physiological states maintained by the CNS activity that is associated with changes in our peripheral, our nervous system, endocrine, cardiovascular, respiratory, and muscular system. The control and regulation may depend on the interrelationship between two cerebral mechanisms that intermittently activate and suppress the brain's higher centers that control sleep and wakefulness. The neurons in the brainstem reticular formation maintain a state of wakefulness, whereas the neurons in the parasympathetic control center maintains a state of sleep. So you have the RAS is wakefulness, and then the BSR is sleep. Of course, there are different stages or phases of sleep. When we have non-rapid eye movement sleep, that is usually 4 stages during a typical 90-minute sleep cycle. Rapid eye movement sleep is REM sleep. And our quality usually from stage 1 through stage 4 becomes increasingly deep. Lighter sleep is usually characteristic of stages 1 and 2, when a person is more easily arousable. The 1, of course, is the lightest level of sleep, usually lasts just a few minutes, and the person can be easily awakened or aroused by sensory stimuli. If they're awakened, a lot of times usually they feel like daydreaming has occurred. When you go to stage 2 and non-rapid eye movement, this is a period of sound sleep. Our relaxation continues to progress. We're still pretty easy to wake up, and often this stage lasts anywhere from 10 to 20 minutes. Our body functions, vital signs, our metabolism all continue to slow down. Stage 3 is our initial stages of deep sleep. The person is more difficult to arouse and rarely moves in this stage. Muscles are completely relaxed, and this stage usually lasts anywhere from 15 to 30 minutes. Stage 4, it is very difficult to arouse the person. Stage 4 is your deepest stage of sleep, and if sleep loss has occurred, the sleeper will spend considerable portion of the night in this stage. Let's say you had just a very few hours to sleep the night before for whatever reason. So a lot of times the next night kind of catches up with you and you sleep harder and maybe longer. Your vital signs are significantly lower in this stage, and usually it lasts somewhere between 15 and 30 minutes. And in stage 4 is where you might see sleepwalking and bedwetting. During stage 4 sleep, the body releases human growth hormone for the repair and renewal of epithelial and specialized cells such as brain cells. So yes, your brain does need sleep. When you look at rapid eye movement sleep, this is where you may have vivid, full-color dreams. It usually begins about an hour and a half after sleep has begun, and if you look at the person, you can see that their eyes are moving very rapidly. If they're connected to a monitor, let's say there may be perhaps your patient in ICU and you're looking at the monitor, you may see heart and respiratory rates fluctuating. The blood pressure may actually go up some. You have a loss of skeletal muscle tone. Your gastric secretions increase during this stage. The person is very difficult to arouse, and usually this stage increases with each cycle and averages about 20 minutes. As we've mentioned before, our functions are why do we have to sleep, of course. Restoration. It is both for psychological and physiological reasons. This REM sleep seems to be very important for cognitive restoration. Researchers associate rapid eye movement sleep with changes in cerebral blood flow, increased cortical activity, increased O2 consumption, and even epinephrine release. This association assists with memory storage and learning. Another reason why you should not stay up all night the night before a big test. You should get plenty of sleep. A loss of rapid eye movement sleep leads to feelings of confusion. Various body functions alter when prolonged sleep loss occurs, such as our immune system, our memory suffers. Dreams are important. They help us with our long-term memory and emotional healing. Our personality influences the quality of dreams. Dreams help people sort out immediate concerns or erase certain fantasies or nonsensical memories. Most dreams are forgotten. To remember a dream, a person must consciously think about it on awakening. And people who recall dreams vividly usually awaken just after a period of REM sleep. So that's why they say the people who are interested in dreams, they a lot of times will have a journal right by their bed or a pad and pencil, and as soon as they wake up, they write down the ideas or whatever they saw in their dream so they won't forget them. Sleep requirements, of course, do vary depending on the person's age, and hopefully by the age of 2, children usually sleep through the night and take daily naps. Some children usually stop taking naps anywhere between age of 3 and 4 often. Some things that affect our sleep are things like physical illness, of course, drugs, substances, our lifestyle. Let's say for some reason we're staying up later one night or a couple nights trying to work on our online courses, and our sleep gets disturbed. Emotional stress can certainly affect your sleep. If you're worried, upset, it's hard to fall asleep often when you go right to bed. Environment. Some people like to have a TV on, a little soft noise. Some people like the soothing sounds of special radios. Some people like it very quiet and dark. And then others want a nightlight on, or they say they have to have the TV on while they sleep. Exercise and fatigue can affect our sleep, and so can food and caloric intake, and of course sound. And as you know, in the hospital, sometimes we forget that it's nighttime for our patients and they need to be sleeping, and we're in there wanting to tell our friends or coworkers about this great movie we went to over the weekend, or about a party you might have went to, or something that you did that was very exciting and you're wanting to share with others. And we have to be very, very careful with being noisy at night, with keeping extra lights on. We should try to dim lights as best we can to still provide safety. And we want to make sure that we don't get on the intercom, hopefully, and page out very much. The environment, besides other things that can affect us, of course, exercise. They say really you shouldn't exercise about 3 hours before you go to bed, because it's kind of going to get you really in higher gear, and it's kind of hard to relax after you've been exercising. Food and caloric intake. Of course, sometimes, especially if you drink alcohol at night, that usually has an insomnia effect often, and diuretic effect. So it's kind of hard to get to sleep and stay asleep if you're having to get up and go to the bathroom very often. Of course, drinks with caffeine can keep the person awake, and medicines that have xanthines in them, like especially your asthma people, their inhalers, some of their asthma medicines will have xanthines in them. Chocolate even contains caffeine. One of the things that they talk to about a lot of our elderly people, they say that almost more than half of people that are 65 and older report regular problems with sleep. So as the people age, their circadian clock advances, and they usually have an advanced sleep phase syndrome. So usually a lot of your elderly people will wake up really early in the morning and not be able to go back to sleep. And so, you may see them getting up at 4 o'clock, 5 o'clock in the morning. L-tryptophan is a natural protein found in foods like milk, cheese, and meats. Can you remember what meat, especially we talk about on Thanksgiving, we get, and it makes us sleepy? So that protein does usually help people sleep. And then noise affects sleep activity because it decreases REM activity. So if you're not getting a good night's sleep because someone left the TV on or something, try having the TV off and see if that it makes you feel more rested. Excuse me. There are a lot of different illnesses or conditions that can alter sleep. Of course, if the person is having difficulty breathing, and if you think about it, if you've ever had a very bad cold and was very congested and you're trying to sleep, excuse me, you can't breathe through your nose, you're laying there with your mouth open and trying to breathe, it's very hard to sleep in that stage. People that have COPD, that maybe have to sleep propped up, people with heart disease, especially if they have irregular heart rate. A lot of times your person will put the call out in the middle of the night and say, I feel like my heart is racing. People with high blood pressure sometimes have trouble sleeping, and ones with either hyper or hypothyroidism. And then, of course, someone that is having trouble with frequent urination, let's say they're having to get up and go to the bathroom often, having nocturia. Someone with gastric reflux. It's not uncommon for someone with severe reflux to wake up with mid-sternal chest pain. Usually people with gastric reflux need to have the beds elevated with a couple of bricks or so to help prevent that reflux from coming back up while they are asleep. Depression can alter sleep. It could either make the person want to sleep too much or too little. And then certainly if you're hurting, it's kind of hard to go to sleep. Some of the medicines that really can aggravate our sleep are, we've already mentioned diuretics if you give them too late. So I always try to check those orders if you've got a late afternoon admission and see if that patient is supposed to get any type of diuretics, and try to go ahead and give them as soon as possible. You have beta blockers, you have benzodiazepines, our narcotics, antihistamines can really bother our sleep. Some people, they make the antihistamine, let's say they take a Benadryl. Some people take Benadryl to go to sleep. Nasal decongestants, alcohol, and we've already mentioned caffeine. Your hypnotics can help, they can interfere, even though some people may be put on a hypnotic to try to promote them going to sleep. Sometimes they will interfere with reaching the deeper sleep stages. So it really only temporarily helps the person, usually about a week or so, because it can eventually cause a hangover type feeling. Your antidepressants and your stimulants, they suppress REM sleep, or rapid eye movement sleep, so that decreases your total sleep time. Sometimes your beta adrenergic blockers can cause nightmares and insomnia. Benzodiazepine, they can increase sleep time, but the problem is they can also increase daytime sleepiness. Our narcotics usually suppress our REM sleep, and they can cause daytime drowsiness. Antihistamines, if you take them in excess, they can cause insomnia. Your alcohol does speed up the onset of sleep and disrupts our REM sleep. And then, of course, caffeine may keep the person from falling asleep, especially if they drink, let's say some people can't drink coffee late in the evening or soft drinks with caffeine. Or if the person can go to sleep, often they'll wake up very easily. Some sleep disorders we need to talk about. Things like insomnia, and I'm sure each one of you at different times has had a bout with insomnia. You may have trouble falling asleep. You may be waking up a lot during the night, and that's considered non-restorative sleep. You all know what sleep apnea is, narcolepsy, sleep deprivation, and parasomnias. Parasomnias, we'll have that again in a minute in a different slide, but those are disorders that produce undesirable physical symptoms as a result of autonomic nervous system changes and skeletal muscle activity during sleep. More common in children. One thing you do find in adults, though, are adults grinding their teeth. And I don't know if any of you do, or if you have someone in your family that grinds their teeth, but that can literally wake someone up. You know, especially like if you've got your child or your granddaughter or something in your room. I do have one granddaughter that grinds her teeth usually about at least once every night or so. You can get the mouth guards to help with that the dentist can actually form to your mouth. Now with sleep apnea, this is a disorder in which the person can't breathe and sleep at the same time. So that would be very difficult to handle. You have a lack of airflow through the nose and mouth for periods of could be seconds or minutes. And there are different kinds of sleep apnea. You can have obstructive, which is certainly the most common, or you can have central, and you can have mixed. Don't worry about the different types of sleep apnea. Mostly what we see in patients is the obstructive sleep apnea. Often you see this with congestive heart failure patients, someone with a brainstem injury, with encephalitis, and you may have someone with mixed sleep apnea. They could actually have either a brain part going on that's causing like a central component and an obstructive component. So they kind of have both. But don't worry about the different types of sleep apnea. With obstructive apnea, the most common form, and it's usually you hear the cessation of airflow despite the effort to breathe, occurs when the muscles or structures of the oral cavity or throat relax during the sleep, and usually have loud snoring. I hope you can hear my sound effects on this slide. The person may have structural abnormalities such as a deviated septum. They may have nasal polyps. Their tonsils may be enlarged. And usually they will try to treat the cause, and the person may even have to have CPAP, which is continuous positive airway pressure, a device at night. The CPAP machine pushes positive air pressure in the airway in an attempt to reduce the apnea periods. It kind of serves like a splint for the airway, if you think of it that way. Narcolepsy is the central nervous dysfunction of the mechanisms that regulate our sleep and wake states. And the person with narcolepsy falls asleep uncontrollably, they don't mean to, at inappropriate times. And, excuse me, usually this is someone like that, let's say they're sitting in the car at the school waiting to pick up children or grandchildren or something, and they fall asleep sitting there in the traffic line, which would be very inconvenient. It is treated with stimulants. And then you have sleep deprivation. I'm sure each one of you has had sleep deprivation at some time in your life by now. And some of the signs and symptoms, your vision certainly can get blurred. You may be kind of clumsy. Your reflexes are slower. It is more difficult to make certain judgment calls, and you can even have cardiac arrhythmias. The psychological signs and symptoms, you can have disorientation, agitation, irritability, of course. And one thing you need to remember, our person in ICU, because if you think about it, those lights are on 24 hours a day, at least the main lights in the nurse's station are their central part. Even if you have the client's room light off, there's still a lot of light in those areas. and the person can actually have ICU psychosis, and you try to get them out and put them in a different area if possible. Now, we've already mentioned parasomnias, and this is where someone can either have bedwetting problems or sleepwalking problems, nightmares. When you're assessing your client for their sleep pattern, ask them what is their normal pattern. Every one of us has a different sleep pattern. So we want to know, do they feel rested when they wake up? Do they keep a sleep log if they're having problems? What is their environment like that they're sleeping in? And of course, always involve your client, and what do they need to do to help them sleep better? Stress reduction. Remember, you can't force someone to sleep if they're really upset. If they're having trouble falling asleep, maybe they need to do something relaxing. I think that's why a lot of people will take a book to bed and read and fall asleep that way. If the child is having nightmares, it is okay for a parent to stay with the child until the fear is over, but co-sleeping is not recommended. This is where you're letting the child sleep with you. Is not recommended, but of course it is seen in some cultures. And I don't know how many of you have let your children sleep in the bed with you, but that's one thing. When a parent does that, it is very difficult to get that child out of your bed. So just remember that. Some of the drugs that we see, that we mentioned briefly, the sedative, hypnotic drugs, these are used primarily to treat anxiety and insomnia. Excuse me. You want to relieve anxiety in low doses, and the same drugs can induce sleep in higher doses, and they work by depressing the central nervous system. 3 pharmacological approaches, the 3 major groups of sedative hypnotics. You have your barbiturates, your benzodiazepines, and then drugs that think they're benzodiazepines. They're benzodiazepine, very similar. The example of barbiturate, of course, as you know, is phenobarb. A benzodiazepine example is Valium, Xanax. And then a drug that acts like a benzodiazepine, something is Lunesta. That's the commercial, I think. I think it had the butterfly on it or something, with a person in the field or something. And you can have miscellaneous type drugs. You don't want to use sedatives and hypnotics for a long period of time, because they can disrupt the sleep even more. You have to be careful about withdrawal from central nervous system depressants, because then the person will have insomnia. That's why they usually try low doses of short-acting benzodiazepines, and they are really recommended for only 2 to 3 weeks. Remember, with your elderly client or the geriatric client, those drugs can remain in the older adult body longer and be potentially dangerous. So they really need to be used at the lowest possible dose. And if you think about it, some of you do work in long-term care, and how many of your residents are on some type of medicine like this, and then it's very difficult a lot of times to get them up in the mornings and all, because they're just groggy. So safety is certainly an issue with someone taking these medicines. The use of non-prescription sleeping medicine is not advisable, because it can cause problems too, such as it can also cause, especially in older adults, confusion, constipation, and urinary retention. Just remember that regular use of any sleep medicine can lead to tolerance, and then the withdrawal will then cause rebound insomnia. Excuse me. Your benzodiazepines are the drug of choice to treat insomnia, and they're also used to induce general anesthesia. You see these used often for seizure disorders, for muscle spasms, for withdrawal from alcohol. The most familiar is probably Valium, and then the most frequently prescribed has to be Xanax, pretty much. This does have a lower potential for abuse and will produce less tolerance and physical dependence. Just be very careful with using these benzodiazepines in the older adult population. Melatonin is a hormone produced in the brain that helps control our circadian rhythm. And so a lot of people take melatonin as a nutritional supplement in the U.S. to help them go to sleep. This just shows you some of the things that they can be used for. And usually they are pretty well tolerated and safe compared to barbiturates. But you want to be very careful giving any of these drugs IV, such as Ativan, or combining oral with other central nervous system depressants like alcohol or barbiturates. So you do not want to combine Ativan or Xanax along with alcohol. Some other adverse effects of benzodiazepines, of course, confusion. Anterograde amnesia is a form of amnesia or memory loss where new events are not transferred to long-term memory. After the onset of this disorder, the sufferer can't recall events that happened just a few minutes ago once their attention has shifted to something else. And in other words, you may see this if you think about if you've been around someone with Alzheimer's or something, they can tell you about things when you were a child or when they were a child, but they don't remember you just told them to go ahead and get dressed or go ahead and put their shoes on, or it's time to go to the dining room for a meal, because their mind is wandering and all of a sudden they forgot what you just said. You also may have weak respiratory depression with your PO drugs. You certainly have abuse of benzodiazepines. This is probably one of the most abused classifications a lot of times with people, and it's not recommended in someone who is pregnant or breastfeeding. They can definitely cause physical dependence. Some of the withdrawal symptoms are anxiety and insomnia, and you have to decrease these slowly over several weeks if the person has been on them for long term. Be sure and teach the patients to not stop taking these all of a sudden. Some drugs that think they're being benzodiazepines, excuse me, of course Ambien, Sonata. These are used for very, very slow, short-term and short-term management of insomnia. The problem with them is a lot of times they can help the person fall asleep, but they really don't work great for people who can't maintain their sleep. Lunesta is one that can be used for long-term use. It does reduce the nighttime awakenings and increases the total sleep time. And so far, there's no indication of developing tolerance to it. The problem with Lunesta, of course, it is expensive. A lot of insurance companies won't pay for it for long-term use, or they'll limit the number of pills that the person can have a month or purchase a month. They are the preferred agents for treating insomnia, but they're not used. They should not be used for anxiety. They are highly effective as hypnotics and do have a low potential for tolerance or dependence or abuse. One thing about Lunesta, though, it will cause the person to a lot of times have a dry mouth and a bitter taste in their mouth. They should avoid high-fat meals because that can interfere with the Lunesta. With barbiturates, excuse me, you have 3 classifications. You can have ultra short acting, short to intermediate acting, and then long acting. And the way they work, they're just to depress central nervous system. When you're looking at the ultra short, those you see those used in general anesthesia because they only last like 4 to 15 minutes, pretty much. The short to intermediate secobarbital, you very rarely ever see that used. You do see phenobarb used a lot. Remember, if you've used phenobarb for an anticonvulsant, but some people will use that for that have insomnia. Make sure you watch the person for dizziness and drowsiness, especially when they first start taking this. With some of the, excuse me, it talks about with the pharmacokinetics, lipid solubility has a significant impact, and that's why you shouldn't take these medicines with high-fat meals. Of course, side effects, respiratory depression, as you know, is the first one. Suicide, abuse, do not use them in pregnancy. Cause like a hangover type feeling. They are a high potential for abuse. And you may see hyperalgesia, which is an increased sensitivity to pain. The person that feels like they're having a hangover from barbiturates, they just really may be very sedated or have impaired judgment or disturbed behavior. If you combine barbiturates with other central nervous system depressants, then you're really going to have more side effects. And of course, with prolonged use, most of these drugs will cause tolerance and physical dependence. And some of them can be very powerful respiratory depressants. And if the person overdoses, it can prove fatal. Some miscellaneous sedative hypnotics. You can have, a lot of times, these may actually look a lot like barbiturates because they act so much like them. If the person has an overdose, then actually the person resembles the poisoning just like barbiturates. And some of these drugs you really rarely ever see. You do not see formaldehyde used hardly anymore. Another drug is something called a melatonin agonist, and this drug is a new hypnotic, and it activates receptors for melatonin, which is kind of a neat deal. And you remember I said melatonin helps us to sleep, but the thing about melatonin, it is usually secreted when it's completely dark. So the ones that's produced by a gland at the base of the brain, and it is promoted by darkness. So the ones of you out there that like to have all the lights on or have a bright TV on, your melatonin secretion may be decreased. This particular drug does have a rapid onset and a short duration, so that means it's really good at getting the person to sleep, but may not be so good as to keep them asleep. Be very careful in using this medicine with someone with hepatic or liver impairment. Some of the basic management principles of sleep, of course, let's try to it depends on the cause. really, of how we can treat treat the client. And non-drug therapy, of course, should always be tried. And then, like some of the drugs we mentioned, your benzodiazepine, remember it's Xanax, Valium, Ativan. Your benzodiazepine-like drugs, of course, Lunesta. Then you may see trazodone or Desirel, as you may be more familiar with it. Antihistamines, Benadryl, very common. And then some alternatives, like in the health food stores, you may see people getting St. John's wort, melatonin, and kava. Remember to ask about over-the-counter drugs with your clients when you're doing an admission as well. Because a lot of those, they think that just because they got them in the health food store, there's no interactions, but they can definitely cause complications or interactions with other medicines too. When we're looking at some nursing diagnoses, and I know I misspelled a word on here, I apologize. Anxiety, and that's supposed to be ineffective, not infective, but ineffective breathing patterns. The person, you may have a diagnosis such as disturbed sleep pattern, sleep deprivation. Some of the interventions we can write on our care plan, particularly in hospitals, environmental control is so important. You want to try to promote their bedtime routines. Ask the person how, what do they do? If this is a child, if you're working on a pediatric floor, ask the parents, what do they usually do to get the child to sleep? Try to keep the bedtime rituals as close as to what they do at home, especially for children, to keep their, and sometimes you see this in people that are impaired too. They do much better if they do the same routine and don't get out of their routines. Some people need to have a bedtime snack. Just try not to make it anything heavy so you wouldn't have problems with it causing reflux. And, of course, trying to teach them stress reduction. Remember, you can close the doors to your client's room in the hospital pretty much as possible. And try to turn the volume down a little bit, maybe on the telephones at the nursing station or paging equipment. And keep our conversations at low levels. This is a lot of times we have trouble with at night. Always remember safety, especially for your clients. As you know, with your residents, keep that bed low to the floor. Make sure they have the call light within reach. Check the side rails. Make sure that the person can get up and go to the bathroom should they need to. And make sure that they've got a clear path to the door of the bathroom. Sorry guys, I forgot to keep my slides going. Now, of course, promoting comfort. Pain management is more than just giving them a sleeping pill. It's more than giving them analgesics. When you want to try to help someone's pain, you need to understand how that pain affects their ability to function. And how can we meet their individual needs? Comfort is experienced in 4 contexts. It can be physical, social, spiritual, and environment. One of these, or all 4, can influence how comfortable a person is, or how they interpret their comfort. With our nature of pain, remember that it's more than just a single physiological sensation. It is very subjective and very individualized. It can be a warning sign of tissue damage. And the problem a lot of times, health providers, tend to be judgmental or have prejudice against people that come in having pain. I realize some of you may work the ER, and I think ER, a lot of times we're sort of notorious for classifying any person who comes in with a migraine to your ER, we automatically think that they're drug seekers. And I don't know if any of you've ever had a migraine, but I have. But because of working the ER, I know that I would never ever want to go to the ER and complain with a migraine. Just because of the way a lot of times we treat the people. And I do understand that people are frequent flyers, as you may call them. There are people out there that are drug seekers, but not every person that comes in complaining of pain a lot of times is a drug seeker. And sometimes it's very easy for us to forget that part. We sometimes, and I'm sure you have heard it before, hopefully you've never said it, where you're in the nurse's station, somebody turns the call light on, and then the unit secretary turns around and says, Mr. So-and-so in room 203 is wanting his pain medicine again. And it is in such a tone like we don't believe the person is hurting. And that is real sad, because so many times, yes, the person may aggravate the desk a lot, especially if we are delaying getting their pain medicine in there to them. Y'all know we do have the 30-minute rule. We can give it 30 minutes ahead of time. But so often, we tend to be 30 minutes late rather than 30 minutes early with our pain medicines. We tend not to get in a hurry often when we're giving pain. Especially if somebody that maybe they've come in a lot, they own a different, there are maybe a lot of pain medicines. And sometimes we do get very judgmental. Often, the reason that our clients are suffering or having increased pain is because we don't assess pain accurately enough or manage it well enough. Remember, JCO requires that all patients be assessed for pain on a regular basis. This has to be documented, and it's usually called the extra vital sign. Excuse me. So just remember, most research shows that nurses and physicians frequently undertreat pain, even in children. Remember, pain is very subjective, and McCaffrey, who was an expert on pain management, he says that pain is whatever the person experiencing it says it is, existing whenever he says it does. So just remember that pain, we have to believe our client or our patient. When we look at some of the physiological things of pain, these are just some terms just to review real quick. Excuse me. You can have transduction, where you have these pain-producing chemicals that are released in response to cell damage. For example, histamines being released. You can have transmission, where the pain impulse ascends the spinal cord. You may have perception, where the person becomes aware of the pain. And modulation is something where it's our protective reflex response that causes the person to withdraw from the source of pain. Remember, pain reception requires an intact peripheral nervous system and spinal cord. And a lot of things that usually cause pain reception can include trauma, drugs, a tumor growth, and metabolic disorders. Some reactions, you may see physiological and behavioral responses after they perceive the pain. Anticipation. Usually that's occurred before pain is even perceived, when we know that something's going to hurt. Let's say, for example, some people are scared of needles, so they don't want to get shots, and they know it's time for their tetanus shot, or it's time for their TB skin test, and then they automatically thinking, because they remember back when they had something else to happen to them. Our physiological responses, of course, it stimulates our autonomic nervous system, and not only do we anticipate pain, then we can have the sensation of pain, and then we can have the aftermath where it's kind of calming down a little bit. When you look at, there's something out there called the gate control theory of pain. And there are a lot of different theories out there depending on which book you read. And this is one theory where a person come up and says the gate control. It says that pain impulses can either be regulated or blocked along by gating mechanisms along our central nervous system. And then pain modalities close the gate by release of endorphins that either prevent or reduce our perception of pain. And as you all know, we usually release endorphins when we exercise. They can also be released due to heat or cold treatment, massage, or a TENS unit. Different types of pain. I'm very aware that you guys know what different types are. Acute, chronic, remission, exacerbation. And remember, acute is can vary in intensity, and usually this is a brief response. The person's heart rate will go up, their respiratory rate will go up, and if the person's having chronic pain is usually associated for someone having pain for 6 months or longer. And someone with chronic pain is usually more difficult to treat than acute pain at times. Of course, factors and influencing pain certainly vary. Just remember that usually our children are under-medicated, and there are different responses sometimes with cultures. And just remember, some cultures it's permissible to holler or carry on. Let's think about the woman having a child. In some cultures, it's perfectly acceptable for her to be in there screaming and carrying on. Other cultures, the person needs to be more stoic and not dare scream, keep very quiet. And for some people, it may be our perception of pain may be based on something that we've had previously or a previous experience. Let's say we had a very traumatic episode with pain. Maybe you've had a acute gout episode, or maybe you've had tendonitis to flare up, and so you remember what that was like before. And another thing is, just remember that pain is not a natural part of aging. And often you hear the comment made, well, they're getting older, so they've got arthritis automatically. We think, well, just because you get older, you have to have arthritis, so you have to have pain, right? But that's not really the truth. But remember that your people who have chronic pain tend to have a much higher percentage of depression. Now, some of the factors, of course, could be either Family and social support also can determine a lot of times how someone handles pain. Now, when we're looking at assessment, you want to try to find the cause, definitely. Try to see what are the effects on that person. And usually it is very difficult for us a lot of times to assess a person with pain, especially if they're hurting very, very bad and they don't even want to talk to you because they're hurting so much. But you want to ask them about the onset of pain, the location, duration. Is it radiating anywhere? How severe? Is it, does something cause it to hurt worse? Or is there something that you can do to make it easier? And just remember, some people may not tell you that they're having pain. That's why we should always regularly ask the person about it, particularly your post-op patients, because they may not think that it's appropriate for you to tell you. You may see the client, you go in and ask them, are they hurting or do they need something for pain? And they say no, but you see that they're grimacing, or you can see by their nonverbal behavior that they really are in pain. Some different classifications, of course. You can have superficial, deep, referred, or radiating. Some of the characteristics, of course. Is there something that causes the pain? Where is the location? Make sure you always ask the client specifically where they're hurting. Do not assume if it's a post-op client and they have an incision, abdominal incision, and they complain of pain, do not automatically assume that it's coming from their incision. The person could be having a severe headache, and Tylenol would do better than a narcotic maybe. So always ask them where they hurt. Of course, you want the severity. Use your pain scales, and there are several of them out there. Remember, with children, we usually use the FACES scales. It's got the pictures usually go from 0 to 5. Wong was one of the persons who published that. Some people use in pediatrics something called an Oucher scale, and that is different. It goes like from 100 down to 0, with 100 being the very worst. But to me, that is more difficult to use because you've got too many numbers. With your adults, you would use a pain scale, usually 0 to 10. And remember to write the number of the pain scale. Often we chart so-and-so is complaining of pain, and we don't put a number. JCO expects us to put a number, to quantify it. And by doing that, then we will know if we're getting better or maybe if the pain is getting worse. We want to know, be sure and look at the verbal versus nonverbal signs. Ask them, how does this pain influence their activities, daily living? For example, if someone is having joint pain or hand pain due to arthritis or something, are they able to get the gallon of milk out of the refrigerator? Can they open the milk? Those kind of things. How does it influence their activities, daily living? And when we're working on the plan of care, what does the client say that they want to get their level of pain to? Documentation, as you know, is most important. We have to document the pain, what we did about it, and always go back and document the client's response to the pain medicine. That is expected, and now with more and more chart reviews, that is one of the big ones that they really look for, is the person following up and checking on that client within the 30 minutes or so of their pain medicine and document. As when you are in clinicals, you will be expected to do the same thing. If you give the PRN, you make sure you go in and document, did it relieve the pain or not. Pain does affect, of course, our sleep habits. A lot of people can't eat if they're in pain. It will affect sexual functioning, our social activities. If it's, if you're hurting, it's difficult to say, yes, I want to go out and go shopping and walk a lot. Pain may aggravate them where they are really having trouble managing their home, household chores or house cleaning may be difficult for them. Some of the interventions we can use, of course, analgesics, and then with analgesics you'll have non-opioids, opioids, and adjuvants. PCA pumps you're familiar with, that's where the patient can control their own analgesia. And often the client can do very well on something called a non-opioid. These are your NSAIDs, your Ultram, your opioids. Examples are fentanyl, oxycodone. Adjuvants are used, not often enough, unfortunately, to really help with the pain medicine. And it's kind of like a boost for the pain medicine itself. These are different things like antidepressants or anti-anxiety agents. Work very well in combination with pain medicine. The PCA pump allows the person to self-medicate. A placebo is something that is considered unethical. I don't know, years and years ago, some of you may remember giving a client placebo, such as going in and giving normal saline as an IV shot for pain. And we no longer do that. Another pain therapy that's used is something called with local anesthetics. And you may have seen this with lidocaine patches. With the PCA pumps, more often you see morphine, Demerol, and even fentanyl used in those PCA pumps. And most of our research shows us that if our post-op patients have a PCA pump after a main surgery, let's say particular joint surgeries or hips, knees, things like that, if they use PCA pumps, they seem to use less medicine because they have the control than people who are having to call the nurse in for a shot every 4 hours. Make sure you educate your patient, though, that it should be the patient pressing the button, not the family member, because sometimes the family member, if they're sitting by the bed, they may press the button every time the person just kind of moves or maybe groans in their sleep or something, and the person could really get too much medicine that way. Your PCA pumps are locked in. They're usually set up by the pharmacist, and that in hospitals we have to chart on a whole different kind of form for that, or if you're on computer charting, there's a special place particularly for PCA pumps. And every shift the nurses have to go in, usually 2 at a time, and review the settings. You just cycle the pump through the different settings and document that they're on the right amount. People have been overdosed by PCA pumps because someone set it up wrong. That machine is only as good as the person who is programming it and the person who is using it. With our topical, local, that's of course absorbed through the skin. You may have epidural pain medicine or even transdermal. I'm sure most of you have seen the fentanyl patches by now. Duragesic is the brand name. Morphine is one of the opioids. and it is from the seed pod of the poppy plant, and it certainly causes pain relief, but it also causes drowsiness and mental clouding. It may make the person have a sense of well-being and reduce anxiety. Usually your opioids are used for moderate to severe pain. And here's just a lovely picture of the poppy field. It does have side effects, however. Respiratory depression is a major one. Sedative effect. Constipation, urinary retention, orthostatic hypotension. Remember, your client getting opioids needs to slowly sit up on the side of the bed and sit there and dangle their feet for just a few seconds before they jump up, because what happens, the person's maybe on Lortab or something, and then they get up too fast to run to the bathroom and pass out on you. You also see opioids used to suppress coughs. One thing you need to remember is that, excuse me, these do have side effects, and I'm sure all of you know for respiratory depression, you give Narcan for opioid. They are high potential for abuse, unfortunately. And there are some patients with different things we need to really be cautious about before administering morphine. And this would be your pregnant clients, of course, a client with a head injury, someone with a decreased respiratory reserve. Some other strong opioids, Durgesic. These are the patches. They're very, very expensive. Usually $25 to $35 a piece. Remember, anytime you're putting a topical, whether it's a patch or gel, cream, on your patient, wear your gloves. You do not want your skin absorbing any medicine. Demerol is for moderate to severe pain. Sorry, guys. It does have a short half-life, and then you may have seen clients on methadone, and that is to help relieve pain and treat addicts. Another strong one, you see Dilaudid. And one thing about Dilaudid, it can come in different forms. So you may see someone, especially with hospice, at their final stages, that they're not able to take oral agents in or swallow PO. They may put them on Dilaudid suppositories. Codeine is certainly very popular, and you see this in cough syrups sometimes that are the prescription ones. It is usually given PO, and the side effects are based really on how much is a person taking, so they're sort of dose limited. OxyContin is one that's probably the most abused. It has gotten a very bad rep because of the publicity of so many people being on OxyContin, and it is a long-acting analgesic. Examples of some hydrocodone, of course, Lortab, Vicodin, you're all familiar with. And propoxyphene, as you know, Darvocet was just recalled recently, the last couple of weeks or so, I think. These particular drugs are used for mild to moderate pain. Stadol is one that works well, but you should not give Stadol to a person that's had a history of heart attack. And someone on Buprenex for a long time can also have liver damage. Your NSAIDs, very, very common. Probably some of you are on NSAIDs. They are anti-inflammatory medicines, and the N comes from non-steroidal. First generation aspirin, the old standby aspirin. Our second generation of NSAIDs is something called Celebrex, which I'm sure you're familiar with. Aspirin is an analgesic. It also reduces fever, and it suppresses the platelets from aggregating or sticking together. So many times people, especially when we have clinicals, the students will say, I'm giving this baby aspirin to my patient because they have a fever, and it's an 81 milligram aspirin. Someone with an adult with a fever would not be given only 81 milligrams of aspirin. So that means that they don't realize that this person may have had an MI in the past, and they're on this baby aspirin to help suppress the platelets from congregating together. It is also used in dysmenorrhea. Does have side effects, unfortunately. Most people complain of GI side effects because it can cause ulcers, gastritis, can cause a person to have GI bleed. It does interfere with their renal system. Children, as you know, we do not give aspirin to them because of the risk of Reye syndrome. And aspirin can also cause hypersensitivity. Celebrex does have fewer side effects than your first generation of your drugs. Used primarily, you see Celebrex in osteoarthritis, rheumatoid arthritis. You may see Celebrex given for dysmenorrhea or acute pain at times. And it does have side effects. Abdominal pain. If someone is allergic to sulfur, they should not take Celebrex. It can cause renal toxicity and dyspepsia. Even over-the-counter medicines such as Advil and Motrin can have side effects. These drugs usually produce less gastric bleeding than aspirin, and often they're used to treat fever and mild to moderate pain and arthritis. They are superior in treating primary dysmenorrhea. Often they are well tolerated. Tylenol is an analgesic and antipyretic, which is fever reducing, but they are not an anti-inflammatory. So that's why Tylenol is not just a drug for one size fits all kind of thing. They're not for everything that's wrong with you a lot of times, and some people really believe in Tylenol. Adverse effects, it can cause hepatotoxicity, and if someone overdoses on Tylenol, it really can cause their liver to literally necrose. There are, you can see these non-pharmacological measures to help relieve pain. And sometimes you will see music used like in the dentist office and all. They're trying to hopefully get you to relax. Some people do acupuncture. Some people use hypnosis or meditation, imagery. You may have massage or a warm bath or ice or even a TENS unit. And of course, relaxation for it. Now, restorative care. These help provide the patient with long-term pain control, and they may have to go to a pain clinic. The patient that qualifies for hospice or palliative care, typically that's a client with 6 months or less to live. And they may have an opioid infusion. And often nurses themselves are the barriers to good pain management in the hospital with our clients. Some cultural considerations. Sometimes when you're talking about morphine, especially, and as a hospice nurse, I dealt with this for many years. The client, when you are trying to get their pain relieved, and let's say the lower tab's not working anymore, So it's time for them to go to MS Cotton. Well, the first time you mention that this is morphine, a lot of times your elderly people just get really upset by that. They, no, I don't want to take morphine because they hear that's the last resort or so. So it will take a lot of education on your part to get them to try and hopefully accept the morphine if that's what the person needs to control their pain. Make sure you do review in either a techniques book or a basic nursing text different types of hot and cold therapies. And depending on what the injury is, it depends on whether you want to use hot or cold. But it can really provide therapeutic benefits. Just remember that you are legally responsible for any equipment for the safe administration of any hot and cold applications. Always check your K-pads if you're using that. And never put a K-pad underneath a limb, underneath the back canal, if at all possible. Because what happens if the person lays on the K-pad, it will literally get much warmer. And I have seen clients burned from K-pads, even with a towel between the pad and the skin. Make sure that the equipment's working properly, because it could have a shortage in it. It could have maybe the temperature control's not working, so it gets too warm. Some of the different types, of course, you may see ice packs, moist or dry. Just remember with your ice packs too, you don't put it on there and leave it on for several hours. Just put it on just for a few minutes and then take it off and let the skin rest. Then go back, put it on another 15 or 20 minutes. You know some of the physiological responses of heat. Of course, it does cause dilation of the vessels. It can reduce muscle tension. It also increases that capillary permeability. Heat usually is good a lot of times for arthritis or degenerative joint disease, maybe a muscle strain. It can also be good for menstrual cramps. And some of the things, when we talked about it being increased in permeability of the capillary membranes, this is where you get delivery of nutrients and removal of waste. It helps improve delivery of leukocytes and antibiotics to the wound site. Promotes that muscle to relax. And helps reduce pain from spasms or stiffness. With cold treatment, this is where you will see vasoconstriction. And it can help with the muscle tension to decrease it. It does cause the viscosity or thickness, if you want to think of it that way, of the blood. And it can be a local anesthetic. Some therapeutics, just remember, it can also reduce inflammation, reduce the localized pain, and reduce oxygen needs of tissues. It helps that injured site to coagulate faster with the blood. We typically use cold immediately after trauma, like let's say sprain your ankle or strain it. It might be a superficial laceration that we can use cold too. And it really depends on like how long is the treatment going to need to be on there, what body part are we applying the heat or the cold to, what is the body surface area of the pain, what is the client's age and physical condition. Remember, our inner aspect of the wrist, forearm, and perineum are very sensitive. Your foot and palms are less sensitive. If the skin layer is exposed, it's going to be more sensitive to temperature. And our body responds best with minor temperature adjustments. If the injury is over a large area, then the person would be less tolerant of any temperature changes. And remember, the very young and old are most sensitive to heat and cold. If a client's physical condition reduces the reception or perception of sensory stimuli, the tolerance to temp extremes is high, but the risk of injury is also high. And I did see this in person with a lady who had poor circulation to her feet. She was a hospice patient we were visiting, and she had them put her recliner, because she stayed in the recliner more, in front of a heater. It was a space heater in the house, and she blistered her feet because she was a diabetic, and she didn't feel that her feet were getting that hot. This is the end of the thing. If you have any questions, please email me or call me at the office. I'll be glad to talk to you about it. Thank you very much for listening.